All right, hi everyone. I hope you guys are having a great day. So in this lecture, we're going to be talking about disorders with somatic features. Thus far, you've probably been at least somewhat familiar with the topics that we've been talking about, anxiety disorders, mood disorders, but today the disorders might be a little less familiar to you. When we talk about disorders with somatic features, we're really trying to tease apart something that is quite convoluted, the relationship between your physical health and your mental health. And personally, I'm not sure that you can separate the two. There's so much overlap, and there's so many ways where your physical health impacts your mental health, and your mental health impacts your physical health. But in this lecture, we're going to be talking about disorders where they might appear to be more of what we would typically think of as a physical or medical condition, but something that's actually caused by a psychological issue, some sort of emotional distress. So please let me know if you have any questions. There will be an activity in this video, activity 8. Remember that your activities need to be at least 200 words long, and they need to be your own original content. Just let me know if you need anything. We're going to go ahead and get started.
Alright, so as I said, today we're going to be talking about disorders with somatic features. So basically today's lecture is going to discuss the fine line between our physical health and our psychological health. So I'm actually going to be doing things in a little bit of a different order from usual. I'm actually going to start off with introducing your activity. So activity 8. What are your thoughts on the relationship between physical health and psychological health? So what I'm looking for here would be your own personal examples, your own personal opinions about the connection between physical health and psychological health, which you will also be getting a lot of information about this during today's lecture. But for example, if you had a client who was having both physical health issues and psychological issues, do you feel like you could help their physical health by helping their psychological health? Another way to think about that might be, if someone's psychological health is harmed, does that mean that their physical health will be harmed as well? So I want you to be thinking about the intricate connection between physical and psychological health today, and I think that this lecture video will give you some extra material to think about as you work on this activity. So when we're talking about disorders featuring somatic symptoms, we need to make a distinction here. So the majority of today's lecture is going to be focusing on disorders that have somatic symptoms. And when we talk about these disorders, you will see that they will involve symptoms that we typically think of as being medical symptoms, but they're not actually caused by, at least as far as we know, not caused by a medical cause, but rather a psychological cause. Now, what you will see towards the end of today's lecture as well is that you can have psychophysiological disorders. You can have disorders that are medical in nature, but maybe are made worse by psychological things like anxiety and things like depression. So a person who already has a heart condition, for example, that heart condition could be worsened by high levels of anxiety. We are going to talk about those kinds of disorders toward the end of today's lecture, but we're going to be starting off talking about disorders that involve what we would consider physical medical symptoms that do not seem to have a physical or medical cause. Now, one thing I do want to note briefly here is that the slide mentions dissociative disorders. There's so much information that I would love to include in this class, but unfortunately I had to make some tough calls about which disorders we would talk about and which ones we would skip. And we are not going to have time this semester to talk about dissociative disorders. But dissociative disorders involve an individual having some rather bizarre symptoms that we would consider very rare. So dissociative disorders are very rare. We don't see them very often. That's part of the reason I didn't include them, as well as the fact that they are not well researched. But for example, dissociative identity disorder is what we would currently call what previously has been called multiple personality disorders. So you can have individuals potentially that might have different experiences, different personalities, different memories that are kind of separated from each other, and so it feels like they're cycling from one person to the next, that kind of thing. Unfortunately, as I said, we're not going to have time to talk about dissociative identity disorder or other dissociative disorders this semester, but feel free to read about that in your book or to look for other resources if that's something that you're interested in. However, we are going to be talking about somatic disorders. So the major disorders we're going to talk about will be factitious disorder, conversion disorder, and somatic symptom disorder. Now, these are going to be disorders that involve physical symptoms that are not, as far as we know, caused by a medical biological cause. So, where do these come from? What do they look like? What do I mean when I say somatic symptoms? Well, people who suffer from these disorders that we're about to talk about have actual changes in their physical functioning. So, we're talking about individuals who their physical health is actually being impacted. They're having symptoms, and we're going to talk about the different kinds of symptoms that can be present, but they are actually having distress and dysfunction from what we would consider medical symptoms, even though they don't seem to have an organic cause or a biological natural cause. Now, what we have to say before we go any further is that it's possible we're wrong here. There is always the possibility that in some of these cases, maybe even in many of these cases, there is a biological medical cause that has not been identified. That's always a possibility, and you need to be aware of that. When you, as a psychologist, try to tell an individual who's suffering from physical symptoms that this is something psychological, they may be opposed to hearing that. They may not be interested in hearing that for several reasons that we'll discuss as we go through today's lecture. But you also have to keep it in mind that there is always the possibility that there's something that we just don't have a test for, or something that we just don't understand yet, that could actually be a medical cause. Having said that, we do know it is possible for a person to have psychological issues that cause physical symptoms. So we're going to start off with talking about what is currently known as factitious disorder. Now, we're going to see that there are two types of factitious disorder. We have factitious disorder imposed on self, so that would be the client, or factitious disorder imposed on another person. With both of these situations, we have an individual who is inducing physical symptoms. If it's factitious disorder imposed on self, the individual is inducing physical symptoms in his or herself. If we have factitious disorder imposed on another, then we have the individual who has the factitious disorder who is inducing symptoms in another person. So we might see, for example, a parent who has factitious disorder maybe inducing symptoms in their child. So the individual who is having the psychological issues is not the one who's having the physical issues in this particular situation. They are inducing those symptoms in another person. Now, this, you may have heard of this. It's previously been known as Munchausen syndrome. So you need to understand the terms here. So you may see that on a test. You may see Munchausen syndrome. It's just another term for factitious disorder. So if we're using the Munchausen syndrome terminology, then Munchausen syndrome would be imposed on yourself. And then you also could have a Munchausen syndrome by proxy, which would be imposing it on another person. In either situation here, we have someone who is inducing an illness in themselves or in someone else. Now, there are many different ways we could do this. It could be by taking a medication or some kind of poisoning oneself some way. There are different ways that you could make it either A, actually make yourself sick, or B, make yourself appear to be sick. Now, we probably understand that this can happen sometimes when a child wants to stay home from school. Maybe they do something to try to make themselves sick, or they stick the thermometer under the lamp when nobody's looking to try to make it seem like they're sick. We're talking about a person who has a pattern here, and this is a significant issue because it can actually create significant psychological and physical problems both in the person who's doing it and the person who's receiving the whatever it is they're giving to try to induce the symptoms if we're talking about factitious disorder imposed on another. So we have a person here basically faking an illness or creating an illness in themselves or in someone else. Now, you might ask yourself, why would a person do this? Well, Somatic disorders are not well researched, unfortunately, because sometimes we do miss a somatic disorder. So sometimes we might have a somatic disorder that we actually think is a medical situation, and we miss the fact that it has psychological variables that need to be considered. So sometimes we miss these cases, or sometimes the cases that we have, people are not honest with us about why they're doing what they're doing. They never want to admit that they induce this themselves. So it is very hard to do this kind of research, although there does seem to be a correlation between things like depression, unsupportive parental relationships during childhood, need for social support. So imagine if a person has had a difficult childhood, maybe had parents that were not affectionate, parents who were not supportive of them, but then maybe their parents were there for them when they were sick. Maybe their parents were never there for them otherwise, but when they were sick, their parents stayed home from work and made them special meals and doted on them. And so you can see how that would be reinforcing if we're thinking about this from a behavioral viewpoint. But also, if you think about Munchausen's by proxy, or about factitious disorder imposed on another person, think about how if a parent has a sick child, oftentimes people will do things for that parent. They'll try to help them, maybe give them money, or maybe just come and do their laundry, help them with things around the house, or just praise them. Like, you're doing such a good job taking care of that sick child. I could never be the kind of parent you're going to be, that kind of thing. So you could see how a person who previously has not received reinforcement or previously has not received social support could find that social support through taking on this sick role in themselves, or maybe imposing that sick role on someone around them. Unfortunately, the treatments for these disorders are also tricky because we don't always recognize it when it happens, and because individuals who are inducing these symptoms in themselves oftentimes are not really open to therapy. They may not be willing or interested in receiving therapy. So with factitious disorder, you're actually sick, but you're sick because you made yourself sick. You took something or you did something to make yourself sick. The person may not want to admit that, but that's what's happening. Conversion disorder has some similar features in that you are going to have medical problems associated with it. The difference is that a person with conversion disorder did not produce these symptoms in themselves, and no one else produced these symptoms in them. A person who has conversion disorder is having medical symptoms that have a psychological cause, but it's not like I'm taking medicine to make me sick. This is something that's happening almost at an unconscious level, if I can use the term unconscious here. So conversion disorder is also different because of the odd and almost extreme nature of the symptoms. So with conversion disorder, the symptoms are typically neurological. At the very least, they include neurological symptoms. There may be some other symptoms as well. So you may see things like paralysis, blindness, loss of feeling or sensation, loss of other sensory information, sense organs. Seizures is also something that you can see when a person has conversion disorder. So what we see is an individual starts having neurological symptoms. Now, you can imagine that of all the symptoms we pay attention to, probably neurological symptoms are the ones we consider most severe, or some of the most severe. When a person starts having seizures, when a person is paralyzed, we're thinking we need to get immediate medical treatment. So this individual who starts having these symptoms will probably then go through a series of maybe painful and invasive medical tests. And of course we need to do the tests, because without those tests we would never know if there truly maybe have been an actual medical cause. But what we'll see is that sometimes individuals who are having these severe symptoms go through all of these tests and we can't find any cause. And in that situation, conversion disorder is something to consider. Now, most of the time this begins between late childhood and young adulthood. So you may see in the teenager, early 20s, this is often when this starts. Now, it's diagnosed in women twice as often as it is in men. Now, these numbers give us information, but of course this doesn't mean that it can't happen in men. It does happen in men. just happens more often in women. And oftentimes it appears during a stressful time period. So although an individual might have a predisposition to this disorder, it's not likely to develop unless a person is put under extreme stress. So oftentimes when we have a consideration of a diagnosis of conversion disorder, one of the first places our mind goes is, okay, what kind of trauma, what kind of stress triggered these symptoms? Because oftentimes there is some kind of major period of stress that triggers these symptoms. Now, conversion disorder is very, very rare as far as we know. Of course, there are all kinds of medical cases going on right now where doctors are struggling to identify a cause, and there may be cases of conversion disorder that go undiagnosed. One of the things about conversion disorder is that because these symptoms do tend to be neurological and because they do tend to be severe, the client or the client's parent, if we're talking about a younger child, they're probably really wanting to find a medical cause and will probably be very resistant to any suggestion that this is actually a psychological cause, which on the one hand I completely understand. If you're having a medical symptom, medical issue, if you're having something severe like seizures or paralysis, the last thing you want to be told is, we're not going to try to find out what's wrong with you, we're just going to send you to the psychologist. You would be afraid that they're missing something medical that needs to be treated, or the symptoms could get worse, or the person could pass away. So I understand why you feel the need to try to push the medical angle. On the other hand, though, a lot of the disorders that cause seizures and paralysis have very bad prognoses. So you don't really want your child to be diagnosed with some of the things that can cause seizures and paralysis and that kind of thing. So on the one hand, I can see both sides. It would be very challenging to be a parent who had a child in this particular situation. So conversion disorders often mimic or look like actual physical disorders, and so this makes it really hard to diagnose. One of the things that we'll do is we'll look for some strange presentations of the symptoms. So for example, there are certain things that usually happen when a person has a seizure. There are certain things, if you have a person hooked up to an EEG machine that's reading their brain waves while they're having a seizure, if there's certain things about the way their eyes, their pupils respond to light. Of course, I'm not a neurologist, but there are certain things that would be expected. So if you have a client who's having seizures, but there are some things going on during the seizures that seem strange, for example, or if you have a client who doesn't seem to have any feeling or any movement in their lower body, and yet sometimes if you poke them, they will move, that kind of thing, there are some odd presentation to the symptoms, or maybe just the order in which the symptoms appear doesn't seem to make sense based on the way the nervous system works. And so that's how a neurologist would first be clued off to the fact that this could be a psychological issue. So you have the presence of at least one symptom or deficit that affects voluntary or sensory function. So this could be paralysis if we're talking about voluntary, loss of sensation, feeling. Sensory could be blindness, could involve loss of hearing, that kind of thing. And the symptoms seem to be inconsistent with any known neurological or medical disease. Of course, there's always the possibility that there are diseases that we have not yet identified. There are many disorders that are being recognized within the last 20 years, and so there's certainly some cases where a person may have a true medical issue that just we don't know how to detect it yet. Now, the difference between factitious disorder and conversion disorder is that with factitious disorder, a person is actually physically doing something that is inducing the symptoms in themselves or in someone else. With conversion disorder, you're not physically, actually, intentionally doing anything to induce the symptoms. The symptoms seem to be happening on their own, but it's psychological in nature, at least we believe. The difference between a conversion disorder and somatic symptom disorder would be the nature of the symptoms. Somatic symptom disorder is similar to conversion disorder in that it does not involve a person physically, intentionally inducing symptoms. These symptoms seem to have an underlying psychological cause that we're not physically causing. The difference is the type of symptoms. So a person who has conversion disorder often has very severe, strange neurological symptoms Whereas a person who has somatic symptom disorder or somatization disorder would have some of the more everyday run-of-the-mill kinds of symptoms. And you'll see in a coming slide what some of those symptoms can be. So they experience some symptoms, and they also feel a lot of anxiety about those symptoms. And so it's a combination of both the distress they feel from the symptoms, which could be like digestive issues, could be headache or other pain issues. They have distress from the symptoms, but then also the anxiety they feel over where are these symptoms coming from also increases their distress as well. Now, these symptoms are less dramatic, things that could happen to anybody at some point. However, they do tend to last a little bit longer than the symptoms we find in conversion disorder. So the patient who has a somatic symptom disorder may have been going around from doctor to doctor for years trying to find the cause of their seemingly random combinations of symptoms. All right, so what we're going to see is that people experience at least one, and often many, upsetting, disruptive physical symptoms or somatic symptoms here. In addition to that, though, they're also going to have some unreasonable thoughts about the situation, maybe feeling like the symptoms are more severe than they truly are, which of course would increase that anxiety. Now, if we know anything about anxiety, we know that it can make it difficult for a person to think clearly about an issue. If a doctor tries to tell you that everything's okay, but you're a very anxious person, it may just feel better for you to get a second, third, fourth opinion, find someone else who might, take what your concerns more seriously, might be a way of thinking about it. So they might spend a lot of time and energy and, dare I say, money on going to different doctors to try to find a solution. So these physical symptoms usually have continued for at least 6 months and could be substantially longer than that. Now, what we see with people who have this somatization pattern is that these long-lasting physical ailments are causing them a great deal of distress. And as I said, they can include things like pain. This could be kind of a localized pain in your shoulder. You could have headaches, or it could be kind of generalized chronic pain that doesn't seem to have a physical cause. So it's not like we were in an accident and then the pain started. The pain just kind of came out of nowhere. We could also have gastrointestinal symptoms, digestive symptoms. We also could have someone have sexual issues. So there is a section in the DSM for disorders related to sexual issues. Once again, we're not going to have time to touch on those this semester. But a person, for example, may feel like an inability to experience arousal, and then as well as neurological symptoms that could happen here. Conversion disorder is made up primarily of neurological symptoms. Somatization could include a neurological symptom, but oftentimes it's more of the pain or digestive issues. Now, as I said, patients will go from doctor to doctor hoping that they will find something that will provide relief for them. So they may have tried a lot of over-the-counter things, may turn to alternative medicine, different things like that to try to find relief, and have not found that relief yet. Now, where do these disorders come from? Well, we're talking specifically about conversion disorder and somatic symptom disorders. So disorders where the medical symptoms have a psychological cause, but they're not being intentionally induced. These were previously called hysterical disorders, or the term hysteria would be used here. And there is a history of how we have previously conceptualized these disorders that we're going to be talking about. You'll probably have noticed as I go through and talk about different types of disorders, I oftentimes talk about where could this come from biologically, where could this come from behaviorally, where could this come from cognitively. I don't often talk about a psychodynamic viewpoint because psychodynamic viewpoints are very difficult to do research on, and I want to try to present you guys with things that we have solid research on. However, during today's lecture video, we have to address the psychodynamic issue because a lot of the early work with hysteria, hysterical disorders, which would now be thought of as disorders with somatic features, a lot of that work was psychodynamic in nature. So we don't have a ton of research support here. We don't actually know where these disorders come from. Not very well, anyway. But when we're talking about the psychodynamic view, of course, when I use the term psychodynamic or psychoanalytic, Freud should be the individual that comes to mind. Freud, the father of the psychodynamic view, believed that these disorders represented a conversion of emotional conflict into physical symptoms. So remember, in a psychodynamic perspective, you would suggest that the problems a person has psychologically come from those conflicts of those unconscious forces. So we talked about the id, the ego, and the superego. We talked about how we have some, from the psychodynamic perspective, we have a lot going on under the surface that we're not aware of, and that those conflicts can then present themselves in various ways. And according to Freud, one of the ways those conflicts could present themselves could be actually having these physical symptoms that don't seem to have a physical cause. Now, Freud had a very specific population that he was working with. So his clients were primarily well-to-do women. And so we do see that women are more likely to be diagnosed with these disorders. But what we saw with Freud, he believed that it had to do with psychosexual development. Now, one of the reasons why Freud's theories are kind of considered off-putting is the emphasis on sex and aggression as well, but especially on sex. But Freud would say that you go through these levels or these stages of psychosexual development. And so as a child gets older, their development changes. So he would say you start off with an oral stage where you get all of your pleasure and you experience the world with your mouth. And this makes sense if you think about babies. This is how they receive food. And if you have a very young child and you put them down, the first thing they're going to do is look for something to stuff in their mouth, which is why you have to baby-proof the house. Then, once you move on from that, according to Freud, the next stage would be the anal stage, where a child's life kind of revolves around potty training. After that, because we're not going to get into extensive detail here, after that, you have what Freud talked about as the phallic stage, which is the stage where a child realizes that he or she has genitals. So Freud believed that the problem, the root cause here of these issues, happened during this phallic stage, which according to Freud is ages 3 to 5. So 0 to 1 would be your oral stage, 2 to 3 would be your anal stage, and then you would have your phallic stage roughly from 3 to 5 years of age. Now, according to Freud, during this time period, girls develop what he coined as the Electra complex. Okay? Follow with me here. And everything I'm saying as Freud would say it. Not necessarily as I would say it, but as Freud would say it. So Freud would say that little girls develop a sexual desire for their father. And because that sexual desire cannot be, and should not be, cannot be met, then they look at their mother, and their mother is a powerful female who is having a sexual relationship with their father. Now, according to Freud, this creates these confused feelings in a girl who once, according to Freud, would have sexual desire for her father and then therefore would be angry with her mother because her mother is the one who is able to have sexual relations with her father. So having that conflict, though, will create a lot of anxiety because the little girl will realize I shouldn't have sexual desires for my father and I shouldn't be angry with my mother. So Freud would say the way that a young girl deals with this is by kind of repressing and burying these feelings and instead becoming attached to her mother, maybe trying to become best friends with her mother, dress up like her mother, love her mother, want to be like my mother when I grow up because she's overcompensating, trying to hide the anger she truly feels towards her mother. Now, lest you male viewers feel left out, there was also the Oedipus complex, which is the male version of this, the idea that little boys want to sleep with their mothers and kill their fathers, which comes from the myth of Oedipus, who did just that without his awareness. He wasn't aware that it was his mother and his father, but that's a whole nother story that you can Google if you're interested. The idea here is that little girls have these conflicts and that the conflict is related to sexual feelings and aggressive feelings, and the little girls feel like they have to repress those feelings. Now, if you have this from a very early age, this mechanism of repressing your feelings, then is it possible that as a girl grows up, she continues to repress her feelings, especially perhaps her sexual feelings, trying to repress those, trying to hide those from her conscious awareness? So when you say to Freud, no, I don't want to sleep with my father, Freud would say, well, you just don't know that you do. You've repressed it. It's unconscious for you. Although that always seemed odd to me that Freud knew more about me than I did, but that's a whole nother conversation. Freud would say that a child has this anxiety that they are trying to repress, and so the conflict that they're experiencing has to break through somehow. But if the conflict broke through as it truly is, it would be devastating to you. If you truly realized that you wanted to sleep with your father and hurt your mother, that would be devastating to you. So Freud would say instead that these unconscious conflicts are going to manifest themselves in a different way. And according to Freud, that way would be these physical symptoms. If we're talking about conversion disorder, neurological symptoms. If we're talking about somatic symptom disorder, things like pain or digestive issues. Now, these disorders, these symptoms are functioning to keep you distracted from the true cause, the true conflict that you're feeling, right? Hope you guys are following with me here. So we're just talking about the psychodynamic view. I'm not saying this is the way it is. I'm saying this is the way Freud would say that it is. So psychodynamic theorists would propose that the primary reason for these symptoms is to keep internal conflicts out of your conscious awareness. Now, there would certainly be plenty of individuals who would say that they have a psychodynamic orientation who would disagree with Freud here and say that it's not necessarily that an individual wants to have sex with their parent. Certainly, there could be plenty of other unconscious conflicts that could cause problems. So, although Freud would say this is probably something with sex and probably something with your parents, not every psychodynamic individual would agree with that, but they would say there's some kind of internal conflict. And so the primary thing that you get out of having these symptoms is a distraction that then keeps your true problem out of your actual conscious awareness. And they would say that's the main reason. However, a psychodynamic individual might also say there is a secondary gain to this. Although the repression of your unconscious conflicts is the main purpose, secondary gain involves having a person either A, avoid unpleasant activities, or B, receive something pleasant as a result of playing the patient role. So a person, for example, might not have to go to work, might not have to go to school, might not have to do his or her chores. Or they might have people come and take care of them, give them money, or bring them food, that kind of thing. So the psychodynamic view would focus on primary gain, but would acknowledge that secondary gain is possible. Now, the behavioral view very rarely lines up with anything from the psychodynamic view. However, they would agree on that secondary gain. The difference is that a behaviorist would say that that secondary gain, as the psychodynamic individual might call it, is the primary reason. So the behaviorist would say the fact that you're able to avoid unpleasant things or gain pleasant things from having these symptoms is at least perpetuating the symptoms and perhaps causing the symptoms in the first place. So they would propose that these physical symptoms are doing something for you. They're helping you in some way. Let me give you guys an example of this that comes from behavior modification texts that I have lectured out of. So certainly there are plenty of medical causes for migraines. An individual might have migraine headaches for all kinds of neurological and other reasons. However, there was a case study where an individual was having migraines and they had exhausted all medical causes, medical treatments, and they just weren't working. So they decided it was possible that there was something going on here similar to this behavioral view. So what they agreed was that this was a woman. So they talked to her husband, they talked to her coworkers, they talked to her friends, and of course they talked to her. They had to get her consent for this, but they said, okay, we're going to make everyone stop reinforcing your pain behaviors. So you're going to have to continue to go to work. You're going to have to continue to do your household duties or whatever. You're not going to get any kind of special treatment because you were sick. And in this particular situation, the person's migraines dropped off to almost non-existent. I mean, they almost completely stopped. Now, that's not to say that that's the cause of every individual who has migraines or every individual who has any kind of pain disorder. Certainly not. There are plenty of other potential causes, but it is a possible cause. When a person is rewarded for being sick, it is natural to have those things that are being reinforced happen more often. The person may not be aware of it, but this might be what's actually happening. On the other hand, the cognitive viewpoint is going to have to do with your attitude, it's going to have to do with your thought processes, and here specifically with somatic disorders, it's going to have to do with a form of communication. So, like the psychodynamic theorists, cognitive theorists hold that emotions are being converted into physical symptoms. So the person who has a cognitive viewpoint here would say, it is your emotional trauma, your emotional issues that are causing your physical issues. It's not that you're being reinforced or punished, like a behaviorist would say. The cognitive view is, it truly is your emotions. It truly has something to do with that. But what's happening here is not that you're trying to repress your emotions. It's that you don't know what to do with your emotions. A person is having emotional trauma, emotional distress, and they don't know how to express that. And so the only way a person knows how to express his or herself here would be through pain, through being sick, through having physical symptoms. Maybe people feel like, I know how to go to the doctor. I know how to ask for help when I hurt. So I'm hurting, even though the pain is actually more emotional. The person might then start to experience physical symptoms because they don't know how to express their emotional pain, and pain is pain, and it feels like they're communicating this way. All right, so carrying on with ideas about where disorders with somatic features might come from, we could also have a multicultural view. Now, a multicultural view would suggest that there's something about our culture that impacts our experience of a particular disorder. So, it is possible that there is something about a Western culture that makes us maybe more likely to have this kind of disorder, or more likely to see this kind of behavior as disordered. So in our culture, we do tend to have what the slide refers to as a bias of seeing somatic symptoms as an inferior way of dealing with emotions. In other words, we tend to, in our culture, separate out physical issues from psychological issues. And I believe what's being suggested here is that that could be an arbitrary line that we're drawing that's not actually there. Is it possible that the overlap between our physical health and our psychological health is much more substantial than we had previously thought, or than we are willing to admit? So we like to organize things and put things in nice, neat boxes, and we like to say, okay, this person has a medical condition, this person has a psychological condition. But is it possible that our health in general is greatly impacted by both kinds of issues, and therefore maybe we're trying to draw a distinction when there is not one? One issue that comes up when we're talking about the multicultural view here is the fact that individuals may experience disorders differently depending on the culture that they are raised in. So it says the transformation of personal distress into somatic complaints is the norm, this should say in, not is, in many non-Western cultures. So, for example, I think we mentioned this in our depression lecture about how in our culture we view depression as being primarily an emotional issue, whereas in other cultures depression often manifests itself in more of a physical way. So people might have more of those things like pain, fatigue, changes in appetite, more of the what we would almost consider biological symptoms of depression. And maybe it's just that the underlying psychological distress is the same regardless of culture, but the way that we experience it and the way that we express it depends on the way our culture tells us it's okay. So those social norms or those cultural norms. We do know that the way that we respond to stress is impacted by our culture, that we learn how to respond to stress from parents, from other relevant individuals in our lives, from the media, from our culture at large. So it certainly does make sense that the way that a person experiences and approaches treatment for a particular disorder might vary from culture to culture. Now, how are we going to treat these disorders? So we're talking about disorders that are psychological in nature that actually cause physical symptoms to be present. Typically, these individuals seek psychotherapy only as a last resort. As a matter of fact, it may be that a person ends up in psychotherapy because their medical doctors, refuse to continue searching for a medical cause. We've exhausted all the medical causes. Clearly, this is something that needs to be handled by a psychologist. Now, you can understand why a person who is having symptoms, whether we talk about conversion disorder having, significant neurological problems, or a somatic symptom disorder maybe having pain, digestive issues, and other problems, you can understand why a person who is having these symptoms would be resistant towards going to a psychologist. First of all, it suggests that we're going to stop looking for a medical cause, which individuals who are suffering from these disorders probably believe that there truly is a medical cause, and so may be afraid of abandoning that and then not getting the treatment they need. But also there is a stigma against mental health issues in our culture, whereas having a physical health issue and going to a doctor is considered common sense, having a psychological issue and going to a psychologist is still considered taboo for some reason. In some situations, a person might experience some stigma here. So a person may be very reluctant to go and see a therapist. If an individual does end up going to see a therapist, then the treatment they receive will depend greatly on the actual orientation and the kind of psychologist that they see. So some of the things that might happen might be similar to OCD treatments. So thinking that an individual who's having these symptoms might have an obsession with their health that might be in some ways similar to OCD, then we might try things like antidepressant medications, particularly SSRIs, things like Prozac, Paxil, Zoloft, that kind of thing, as well as exposure and response prevention, which is that behavioral treatment that we talked about for OCD. And then also therapies that include a cognitive component, so trying to change the way that people think. Now, when we're talking about a few specifically psychological interventions, not medications, but a few specific things we can do, some psychologists might suggest something like hypnosis. Now, there are certain kinds of treatments that are associated with certain kinds of theoretical orientations. We would expect that someone who had a more psychodynamic, psychoanalytic orientation would be more likely to suggest something like hypnosis. On the other hand, if you're a behavioral psychologist, then you would probably want to think about reinforcement. You want to think about how the symptoms that the individual is experiencing have been reinforced by the environment, and then how maybe we can switch that up, where an individual maybe is no longer reinforced for those symptoms, but the person still needs reinforcement. Reinforcement is not a bad thing. We just want to make sure that we're reinforcing good behaviors. We want to reinforce appropriate behaviors. So if we could reinforce a person, for example, for going to work anyway, even if they don't feel well, and then giving them that reinforcement that they need for well behaviors instead of for sick behaviors could potentially be helpful. And then when it talks about confrontation is something that would probably happen with a primarily cognitive orientation here. The idea that your sick role is not logical, and so we need to try to confront the client with the logic behind, okay, well, your medical health is fine, you're having these symptoms, and we need to talk about that and try to force the client out of the sick role. Now, there are many different ways to approach this confrontation, but what I will say is that you need to develop a really good relationship with your client before you start trying this overt confrontation, which, if you are working with a client who has some of these physical symptoms, that client is probably already not sure they want to be in therapy at all. So I would make sure that you develop a really good relationship with your client before you start in on confrontation. Having said that, Because these disorders are relatively rare and not well understood, we don't have much information about how well these approaches actually work. Basically, we're saying these approaches seem to work for some other psychological problems, so we think that they would work here. Now, when I talked about things like factitious disorder, conversion disorder, somatic symptoms disorder, we're talking about individuals who have a psychological cause that is actually producing physical symptoms. Illness anxiety disorder is different in that these individuals are not experiencing symptoms, at least not anything that's unusual in an individual. So a person who's having somatic symptom disorder may be having severe pain. A person who has conversion disorder may be having seizures. But a person who has illness anxiety disorder may have something like a cough or sweating. Things that are typically found at some point in your life among everyone. But people who have illness anxiety disorder, they unrealistically interpret the symptoms they're having as a sign of serious illness. Now, a couple things to say about this. First of all, this diagnosis previously would have been referred to as hypochondriasis. So you probably heard of a hypochondriac. Our terms have to change throughout different editions of the DSM, if for no other reason than stigma becomes associated with certain terminology. So we switch to different terminology to try to reduce that stigma. The thing about illness anxiety disorder is I feel like this is, I don't have any research to back this up, but it makes sense to me. This would be worse when you have more access to the internet. Think about if you start Googling, I have a cough, I'm sure before you're done Googling, you'll find all these case studies of it was just a cough and I ended up being lung cancer, it ended up being something terrible. And okay, so a person who has minor issues that are just normal parts of being human, if that person already has a high level of anxiety and then that individual is confronted with something they see on the internet about someone who had similar symptoms, you can see how this person could become severely anxious. Now, some individuals with illness anxiety disorder recognize that their concerns are excessive. They'll say something like, I'm sure it's nothing. I know I shouldn't be worrying about this. I can't understand why I keep thinking about it. It once again has an OCD-like quality where the person is obsessing over their own health. However, some individuals do not realize that their concern is excessive. So, just like someone who has a somatic symptom disorder, these individuals may bounce around from doctor to doctor trying to find someone to validate their anxiety, to validate their concerns, and they may be very frustrated and angry when a medical doctor refuses to acknowledge the severity of what they feel is a severe symptom. So I have the criteria here for you. So the person's preoccupied with thoughts about having or getting a significant illness. So the person may not even think they have the illness yet. They just think they're at risk for it, or they're concerned about contracting some illness. And in reality, this person has no symptoms, or if they do have symptoms, they're very mild and just something you would expect to find at some point during everyone's life. The person has easily triggered high anxiety about health. Once again, probably one of the easiest triggers to get hold of would be the internet. So this person may do excessive research into health-related issues. So because of that, the person then becomes obsessed. And so they might have a lot of health-related behaviors, things like checking, maybe keeping track of, maybe measuring their temperature, measuring their weight excessively, checking their blood pressure, whatever the case may be, excessively. And the person's concerns continue at least for 6 months. So we have some disorders where you're actually having symptoms, but they're being caused by psychological causes. We have disorders like illness anxiety disorder where the psychological thing is making you think you're having symptoms when you're not really having symptoms. But a third possibility here is that you truly do have a medical condition and then a psychological condition is impacting your medical condition. So this could be called psychophysiological or psychosomatic disorders. Could also be called psychological factors affecting a medical condition. So there are several different ways to say this, but basically what we're saying is that your physical health here already has an issue, but is being impacted, probably worsened, by your psychological health. So an individual who is in this position of having a psychosomatic disorder, they need to be under the care of a medical doctor to make sure that the medical issues are being treated, but they would also need to consider psychological treatments because the psychological problems are impacting the treatment of their medical issues. So we have the criteria listed here. First of all, the person already has a medical condition. So we're not suggesting that this medical condition is caused by a psychological condition. We're saying that your psychological condition makes the medical condition worse. So, for example, it talks about affecting the course. It could be that because of a psychological issue, your medical issue worsens more quickly. The person goes downhill more quickly than we would normally expect. Or it could be that your psychological condition provides obstacles for the treatment of the medical condition. So because of a psychological condition, you do not seek out treatment, perhaps, that kind of thing. People who have anxiety disorders oftentimes engage in avoidance behaviors. So then a person who, for example, knows that they have a significant medical condition might, because of their anxiety, not seek out medical care because it makes them feel more anxious to do so. Can pose new health risks, trigger or worsen the medical condition. So you might be wondering at this point, what medical conditions can be impacted by psychological issues? There are several. More than we could list in this particular lecture, but just as an example of some, ulcers, right? So ulcers would be considered a medical issue that a person has. We have lesions in the digestive system, oftentimes in the wall of the stomach, but you could also develop ulcers in your mouth, for example. So really any part of your digestive system, your digestive tract, that results in burning sensation, pain, vomiting, stomach bleeding, and relatively common. Over 25 million people at some point in their lives experience ulcers. Now, if an individual has ulcers, it may be because of a diet-related issue. So the doctor may have some diet suggestions for you. Maybe there's some medications that you can take. But we may also be aware that your psychological condition can impact ulcers. So we use this, we just throw this around like, don't worry about things so much, you're going to give yourself an ulcer. We say things like that. Well, it is true that environmental pressure, stress, anger, anxiety can also create ulcers or make the ulcers you have worse. And it talks about infections here. How is that related to your mental health? Well, your immune system functions to protect your body from infection. And extreme stress can decrease the effectiveness of your immune system. So once again, psychological factors impacting medical factors. Asthma is another example. So asthma occurs when your body's airways narrow, making breathing difficult. Some individuals have asthma from an early age. Some individuals develop asthma as they get older. Asthma can be related to issues like allergies and things like that. Relatively common, once again, up to 25 million people in the U.S., so a lot of individuals suffering from asthma. Now, asthma is a medical condition, but of course, when we're talking about something like asthma that's related to your breathing, you can imagine if a person starts to have a little bit of a difficulty breathing, a little bit of a narrowing there, can you imagine how that could make you anxious? And then that anxiety could trigger a panic attack that could make breathing even worse. So an individual who has asthma might need medical treatment, but might also need a psychological treatment, maybe similar to something like we do with panic disorder. So also, once again, if we're talking about things like your immune system, your respiratory system, your nervous system, all these things are related to your psychological health. What else? Insomnia, which is characterized as difficulty falling asleep or staying asleep. So you can go to sleep easily and then wake up in the middle of the night and have trouble going back to sleep, or wake up several times throughout the night and still be diagnosed with insomnia, which affects about 10% of people in the U.S. each year, so this is extremely common. And something that I actually hear quite a bit from college students as well. Now, insomnia can be a medical issue. There could be something going on where you actually need to see a medical doctor. There could be some kind of medical cause. But oftentimes there are psychological causes that are at least involved, if not primarily the cause of the insomnia. So we tend to see insomnia in individuals who have anxiety disorders, depression, overactive arousal system. So this might be someone who has a trauma-related, stress-related disorder here. What we also see is that sometimes this happens when people just are not taking good care of themselves. So there are, of course, medical treatments for insomnia, medications that you can take over the counter or prescription, but we're going to talk about drug use later. But anything that you use that helps you go to sleep can become you can become dependent on it. So there is such a thing as a behavioral treatment for insomnia, which basically focuses on sleep hygiene. So briefly, without going into any great detail, you should be on a sleep schedule where you go to sleep at about the same time and wake up at about the same time, even on the weekends, which I can hear you rolling your eyes, but that's something that's good for your brain so that it knows when to go to sleep and when to wake up. Engaging in some kind of calming ritual before bed, so you're kind of triggering that, hey, it's sleep time now. It needs to be a calming activity, so maybe something like reading a book or taking a shower. There's a reason why we bathe babies right before bath time, or sorry, of course you bathe them. We bathe them right before bedtime, and the reason for that is when your body gets colder, your body says to itself, oh, I better shut down and conserve energy. It's almost like your body is preparing itself against hypothermia, which of course we do not recommend doing anything that could even potentially trigger hypothermia in yourself or your children. But what I'm saying is that taking a shower lowers your body temperature when you step out of the shower, and the lowering of your body temperature can make a person feel more tired. Avoiding any bright lights or screens, so don't be looking at your phone or the computer or the television within at least 30 minutes of bedtime. Don't use stimulants, things like caffeine or nicotine before you go to sleep. Alcohol is also not great for sleep. Surprisingly, well, I'm sure we'll get into this when we talk about substances, but alcohol use can suppress REM sleep, so it's actually not great for your sleep quality. So there are things that you can do to try to impact your sleep in a positive way that would be considered more behavioral therapy kinds of things than anything else, with no side effects. Great. All right, moving on. Chronic headaches. So some individuals experience things like tension headaches, migraines, so they have headaches on a pretty regular basis. Of course, headaches can be caused by medical issues, and so it's a good idea to check this out with a medical doctor as well. But things like depression, anger, anxiety can produce headaches. So we talked about how sometimes we have things like pain that are present in issues like depression. So this can be psychological in nature. It can have to do with stress, so a person who has difficult time relaxing. Abnormal serotonin activity could also be an issue here, so that would be treated with medication like an SSRI, that kind of thing. Vascular problems would have to do with blood flow, muscle weakness. So it could be that a headache issue is caused by a medical cause, but then made worse by things like stress, anxiety, and others. Hypertension. I think that the number of people being diagnosed with high blood pressure is probably increasing. I think the average age at which a person starts having blood pressure issues is probably also lowering, and so I think this is a major issue for our culture at this time. So high blood pressure, there are several factors to take into consideration, but if a person has high blood pressure, they're at risk for other health-related issues, particularly heart disease and others. So it's obviously important to try to reduce a person's blood pressure. Now this can be done with medication, can be done with psychological treatments, or could be a combination thereof. You will see that some individuals have a family history of high blood pressure, and that might suggest that there's a biological cause there. But even individuals who have a biological cause for their high blood pressure would still benefit from some kind of psychological treatment. So we know that things like stress and anxiety, this is kind of starting to sound familiar at this point, can increase your blood pressure. So If you're an individual who has naturally high blood pressure, you might want to seek out treatment for psychological issues that you have, if for no other reason than it's good for your physical health. So other things that doctors might suggest, maybe losing weight if you are not of a healthy weight, stop smoking, or using excessive caffeine. My research on caffeine and high blood pressure suggests if you're a chronic caffeine user, it may not impact your blood pressure that much. But if you're an individual who's not used to caffeine, then that can have negative impacts on your blood pressure. Kidney function is something they would check out as well. So high blood pressure can be treated with things to help improve your psychological health as well. On a related note, coronary heart disease, which is something that's happening more and more often. Oftentimes when we hear about things like heart disease, we think about obesity, an unhealthy diet, lack of exercise, that kind of thing. But the unhealthy diet and the lack of exercise can also be related to psychological issues. A person who's depressed may not have the energy to exercise, or may binge eat unhealthy food because it's a source of comfort. We're going to talk about eating disorders later. So obviously there are several problems associated with blockages in your coronary arteries, things like heart attack, stroke, other major issues here. So things to consider: job stress, which of course the answer may not be to quit your job, but maybe there's something you can do to try to reduce the stress that you feel at a job or at school, whatever you're doing right now. High levels of anger or depression can also be associated with coronary heart disease. And then cholesterol, obesity, we already talked about high blood pressure, smoking is very dangerous, which you can use behavioral treatments to stop smoking, but we'll talk about substances later, lack of exercise. All right, there are many other psychological issues impacting physical issues that we could discuss. Today we're just kind of touching on the surface here. Behavioral medicine is a field that combines psychological and physical interventions. So I recommend behavior modification techniques. I've already told you guys I have more of a behavioral viewpoint, more of a behavioral orientation. I recommend behavior modification for anyone and everyone, for everything, basically. But if you're going to be a doctor, or if you're going to be a kinesiologist, if you're going to be working with individuals, you need them to follow through with the treatments that you prescribe. You need a person to take their medication, to do their physical therapy, to go see their doctor. And so you might take an individual who has purely medical problems, but then using behavioral techniques, reinforce them for doing behaviors that are good for them. Reinforce a person, for example, for the right kind of eating behaviors, the right kind of exercising, the right kind of sleeping behaviors. So certainly there is room in the field of medicine for psychological behavioral treatments. What might some of these treatments look like beyond just reinforcing someone for taking their medication? Well, relaxation training is something that can be helpful for individuals who have medical conditions. It lists a few of them here. Relaxation training can treat high blood pressure, chronic headaches, insomnia, asthma, pain, blood flow issues, potentially side effects that are associated with certain kinds of treatments, that kind of thing. Basically, during relaxation training, a psychologist or a medical doctor would train a person to kind of force their body to calm down. So there are a few different ways to do this, but a couple of the most common ones involve deep breathing and progressive muscle relaxation. So obviously, beyond the scope of this class, if you're interested in this for your own personal mental health, physical health, then by all means feel free to Google this. I'm sure you can find YouTube videos that show you how to do progressive muscle relaxation, that kind of thing. But when you're talking about things like progressive muscle relaxation, basically you are alternating contracting and relaxing different muscle groups and focusing on the difference between when your muscles feel tense and when your muscles feel relaxed. And that can be combined with deep breathing. The thought is that this is a pretty effective treatment for some anxiety disorders. So an individual, maybe for example, who has a specific phobia, might be doing some of this while they are brought in contact with the feared object. Or a person who has panic disorder might use these techniques to calm themselves down if they feel like a panic attack might be imminent. So in addition to the actual medical conditions we can treat, we can also treat psychological conditions with this as well. Meditation is something that has been practiced for quite some time. Of course, there are many different ways to practice meditation. Some individuals are more open to this than others. Recently, though, there has been a trend towards more holistic medicine, trying to include several different aspects of a person's experience in their treatment. So meditation is just basically any kind of technique that turns your concentration inward and helps a person to relax. So this may be considered just another form of relaxation training. So meditation is something that might be taught by a psychologist, might be taught by a religious leader, might be taught by a medical doctor. Meditation has been used in the research to manage pain, treat high blood pressure, heart problems, insomnia, and asthma. Okay. So in addition to some of those relaxation techniques, we could also have cognitive interventions. Basically, we are trying to change the way a person thinks about their own health and wellness. So sometimes people who have physical ailments have attitudes about their physical ailment or about treatment that are not helpful. A person who has no hope that the treatment will be effective, or a person who feels like their medical condition is permanent and so therefore there is no point in trying to treat it. Or, well, I take the medication, so why do I have to do anything else? I'm already on blood pressure medicine, so why do I have to do anything else for my blood pressure? So there may be some thought processes that if we change them, the client could benefit from. One intervention that's interesting is called stress inoculation training. Now, an inoculation, it would be a similar idea to a vaccine. The idea that if you give someone a weakened, deadened version of a virus, for example, then the body's immune system practices with that and learns how to respond to produce antibodies for that illness, so that if the person ever later comes in contact with that illness, their body is prepared to fight it off. Stress inoculation training happens the same way. We're going to say that you are going to come in contact with stress at some point during your life. Maybe at some point every day you come in contact with stress. So if we have an individual who doesn't know how to respond to stress, that's going to make things worse. So bring a person in, talk to them about stress management techniques, and then with stress inoculation training, we actually practice it. We put the client under a little bit of stress during the session with the psychologist present so they can practice using their relaxation techniques or whatever. The psychologist can provide, adjustments or can help them practice, and then later outside of the psychologist's office, when they run into stress, they will be prepared for that. All right. Now, of course, combinations are often considered the best thing we can do. So we can take psychological interventions. We can combine them with medical treatments, or what we would consider, historically medical treatments. We may see the best effects here. The problem is that individuals who are having medical conditions may not be open to a combination. As I said, many individuals who are concerned about their physical health are so zero focused in on the physical health that they completely miss, they think it's irrelevant, or they think it's demeaning to suggest that they might need a psychological treatment as well. So people may not be open to this combination. Of course, it's also possible people may be resistant in the other direction. So someone may say, well, I'll talk to a therapist, but I don't want to be on a medication. I don't want to have someone controlling me with a medication. I don't want to become addicted. I don't want to have side effects, that kind of thing. So, of course, each particular situation is individual, so you would need to talk to your own healthcare professionals about that. But oftentimes, combining a psychological treatment with a medical treatment produces the best results. So that is the end of this lecture video. Please let me know if you have any questions. Don't forget about your activity, looking for your thoughts on the relationship between physical and psychological health. So let me know if you guys need anything. Otherwise, I will talk to you during the next lecture video.